Good afternoon, everyone, and I hope you've had an amazing week. I know it's been a different experience for me to come to such a forum with people that aren't always working on the same thing as me. It's been amazing to meet so many innovators and social entrepreneurs this week. And I was going to start by, outlining what we face in terms of challenges for the pandemic. But we have so many experts in the room, and I realize we all have lived through the pandemic. We're all experts in our own way. And so I don't think we need to really rehash what we've just been through and what we continue to go through. So I hope today we can really hear about some of the new innovations, but also some of the basics and the way that we need to build a comprehensive system. I think the real lesson for me out of the pandemic, after working on health emergencies and disasters for the last 18 or 20 years, was really how much the pandemic exacerbated inequity. It found every gap in our system and it exploited that system. And so the need for a comprehensive approach beyond health is a critical piece of our pandemic preparedness. And it's not just the health teams that we need to engage, but it's the social safety nets and the food security and the transport and the communications. And so I hope today we can think about these health innovations and the work that the panelists and to some extent myself have been working on, but think about how that fits in the overall structure. The other thing I'd like us to think about is, as we prepare for the next pandemic, have we done enough to solve the pandemics that we're already facing or still facing? And I think the critical piece for me there is the 7th cholera outbreak or pandemic that was declared in 1962. At the moment, we face 24 outbreaks around the globe with some of the highest case fatality rates for a disease that we've known how to solve and to prevent for decades. So as we think about innovations, as we think about how technology can get us ready for the next pandemic, I also want us to reflect on why we're not doing enough to save lives from things like cholera, when we know soap, water, chlorine, access to sanitation could save so many lives. So as we challenge ourselves today to get ready for the next pandemic, I also want to challenge our panelists a little bit about how we make sure that we finish the job that we've started on so many outbreaks and save lives today, not just for those outbreaks we face in the future. So with that, I would really like to welcome our panelists to the stage. So we're going to keep it informal. It's Friday afternoon. I'm Australian. It's already time for a beer. So we're going to keep it... We're going to keep it really casual, and I'm going to ask Dr. Patipat to join me, Angela, Christian, and Raj to the stage. And I have to say, this morning I tried to memorize everyone's bios, and Raj, maybe to start with you, I had no idea which place to start between board member, US government representative, NGO president. So I'm going to ask you all. Yeah. I'm going to ask each of our panelists just to take 5 minutes to introduce themselves and the projects that they've been working on, and then really get into how those projects are linking to the overall system. So maybe I can start with you, Pat, a little bit about yourself and the project that you've been working on in relation to the pandemic.
Yeah, sure. Swasti krab. Thank you very much for inviting me to the Skoll.org forum. It's my first time here. It's really nervous and exciting for me. My name is Patipat. I'm from Thailand, and my background is computer engineering. So around 15 years ago, I get to know friends from like they are working for the sister organization of Skoll Foundation, and they introduce us to the work of the how can we like prevent the pandemic, that kind of thing. It's really exciting for me from engineering perspective. So like, oh, exciting work. So we should work on it. And basically what we have been doing in Thailand right now is we try to look into the data, like public data or the citizen data, participatory data. How can we use that to estimate the risk and prevent the community outbreak, and subsequently prevent the next outbreak in the future. So our initiative, now the initiative that we are working on is we try to turn the farmers into the disease detectives. And we enable them with the mobile phone and a simple application, so they can take a report of any health, suspicious health event in their community. We build the system to help them evaluate that is this has a high risk or low risk, and then we build a notification system for them to take a response. So we tell them if there's, for example, like if their backyard farm, backyard livestock, and it has like 10 chicken dies, what's the risk of that, and what you could do, what you can quarantine, and we enable them to take an action before waiting for the government or the livestock agencies. And just by doing that, we can reduce the time to detection from multiple weeks into like just 72 hours, and like time to respond from multiple months into like 74 hours. So that alone can reduce the risk of the spillover of the pathogen from animal to human. And currently we are trying to open source our system, and all the knowledge, all the codes, all the mechanism that we have learned in the past 9 years into the open source system, so every community in the world can adapt and make their own participatory surveillance system, and moreover than that, we trying to go into currently. I heard a lot of like AI, ChatGPT kind of thing. We try to build like predictive model for the community and the local government to like what would be the next health threat in their own community, so they can prepare and take action accordingly.
Excellent. Well, that perhaps leads me on to you, Angela. If we're turning farmers into disease detectives, you're potentially turning communities into scientists.
Yeah, I would say maybe taking some inspiration from Kathleen, who's right here, who talks about scientific communication. Actually, it's communicating. Science has its place, but what's the use of science if it's sitting on a complicated dashboard and doesn't really serve the last mile, or should I say the first mile? So my name is Angela, very quickly. I'm a public health professional like most people in this room, and health equity drives me. And so for the last 20 decades, having worked in 25 countries, I lead a platform called Swasti. Swasti means well-being in Sanskrit. And we work on catalyzing everyday health and well-being for some of the world's most vulnerable populations. And when COVID hit us, we all knew the repercussions of COVID was going to be deep and it's going to be wide. And we knew that there's going to be diagnostic stockouts. They were not going to be the ones who's tested. They're never going to know what their risks are or their additional vulnerabilities, like they needed more vulnerabilities already. And so we had to look for an easy scientific problem to be able to solve it. And so when the KW Water Research Institute in Amsterdam presented their paper in Nature, said, hey, we're able to find strains of COVID in wastewater, we said, I think this is a good thing. Let's test it in open drains, because a city like Bangalore, serving 13 million population, had several slums, and those were obviously the ones that were left out. And there were surveillance programs for sewers. I said, but I really want to know what that population is going through. Will it work through rain and through sunshine and through all the synthetic material that goes into that? And when we have this information, how are we going to make sure that that information reaches and the populations are able to do simple things like wearing masks, or even getting over their vaccine hesitancy if they had that, or even demanding for health services. We also wanted that information to be easily translatable to the government, because they don't understand scientists, and the scientists don't understand the priorities of administrators. So there's always that tension everywhere. This is not an Indian phenomenon. I think that's a global phenomenon. And COVID drew us to collaborate with diverse sectors to be able to make that happen. And so that's what this, Sosi does a few things, but this is the reason I'm here today. And so Precision Health Platform is essentially an equity-driven platform that translates science into communication that people can do something about.
Fantastic. And I think it's that systems approach, connecting equity to data, to the science translation, to action, that really makes some of these projects so successful. But Dr. Christian, can you tell us a little bit about yourself and your projects?
Yeah, Christian Happi is my name. I'm at Remus University in Nigeria, and I lead a center called the African Center of Excellence for Genomics of Infectious Disease. A few years back, I think I made a decision that was called irrational at the time because I was Harvard, and I made that decision to go back to Africa and Nigeria. And the question was, why did you go back? I said, well, I think, this whole idea of genomics, I see a huge divide between the rest of the world and the continent, and I'm here doing it, and I keep seeing, this huge gap. And I felt maybe going back and try to use that and empower, the young researchers in Africa and apply that to infectious disease was going to be the solution, because I always seen genomics as the great equalizer. And why did I thought that doing that for infectious disease was going to be great is simply because of what we know now. 70% of these pathogens that have pandemic potentials are all in Africa. So you look at that and you realize that, well, there is really an opportunity here for the continent to contribute significantly to global public good and then global public health. And in doing that, we'll go back and then we'll set up this platform. And we got first funding from the World Bank to do that. That is in 2013. And right in 2014, we have this Ebola outbreak. And immediately, we put the knowledge and the skill into action. We go on and then do real-life, near real-time sequencing of the virus. That's for the first time in Africa, showing how you could use this to respond to an epidemic. We did that. We went on to demonstrate that you could actually see some of these mutations that are associated with increased transmissibility, release the first 99 genomes in real time, share that open data sharing, open data access. And we use that. Unfortunately for us, we work in a setup in a place like Nigeria where the people in government understand the value of working with academic institutions. And Nigeria really gets saved out of, beat Ebola simply because there is that strong connection. We get the very first case of Ebola within hours. We get the testing done. The next 2 days, we have the sequence available. The government takes it and work with it, and we work with government. And then this is a country of over 230 million people that beats an epidemic like Ebola in 93 days with only 20 cases and 8 dead. So that really was the first demonstration that this can work if you really can get this integrated and work with public health officials. And we went on, to unravel, epidemics like yellow fevers. You have children dying somewhere, we don't know the cause. And I do remember at the time, I had a very smart guy called Chikwe who was heading the Nigeria CDC, requesting the sample to be sent to us within 72 hours. We know that we have yellow fever. But then this yellow fever seems to be very different from what has been circulating in the country for 92 years. This information is given to him. He goes on and they declare an outbreak, contain that. So you could see these applications. And that really gave us the confidence to know that we could do it and do it in a way that wasn't done before. So through the Skoll and then other funders, we applied for the third audacious project. Mm-hmm. So we got this funding before COVID started. And then the whole idea behind it was to set up the Sentinel program, which is for us an early warning system for pandemic preemption and response. Mm-hmm. And as COVID hit, we were actually just called to test that whole program that we said we actually got funding for. But we have to struggle and then get this into action. So we actually again demonstrated clearly that you could really move faster than we ever thought, right? Went on in the case of, for Africa, for instance, Nigeria is the third country to have, to declare COVID. We had Egypt, we had South Africa, Nigeria is the third. But in 48 hours, we have the genome. Then we make it available. Then we share the protocol across Africa. And say, this is how we can do it. Because you got two things to beat an epidemic. I've gone through many. One is speed of execution. Second is accuracy. So once you get those two things, you will beat it. And then we went on again with that, shared information. The government knew exactly that it's not local transmission. It was important. We know exactly where that came in. And then you get leadership within the country. Who, again, my great friend Chikwe will get report from me every week, every Saturday. They use those reports to do, the Presidential Steering Committee, This information, so that is a situation where you're having from the president, from the top to the bottom, they use data to respond in the country. We knew in the case of Nigeria at times that we know 49 different variants. We know where they are. We know how they're circulating. These are how you use data to respond to an epidemic. But to actually show really that in action is that we work with the Africa CDC, and within this epidemic or pandemic within Africa, we train people from 42 different African countries, replicate exactly what we do. So if you've seen our colleagues in South Africa picking up Delta or Beta variant and Omicron, this is exactly what we did. We shared the secret sauce and then they use it. So it shows clearly that there's, if you think about sharing, it's part of what we think about, global, we'll talk about that later on. But then we also made sure that we support African countries that did not have the facility. So we have sequence sample from 38 African countries. So, and as such, data are very important to help get response. So most African governments, as people tend to say, oh, well, we didn't know what was happening, or we don't, we're not testing enough. Of course, we didn't have all of the testing in the world because, of course, there was a barrier for reagents and things not to come to the country, but the little available that they had, they used data to respond. I can tell you with confidence that most African countries, I can go government by government, they use a lot of data to respond to epidemic in their countries. So this said, this is the kind of thing that we're doing, creating the next generation diagnostics that is using the CRISPR, that is, a gene editing technology to create, because we don't just sequence. We sequence, we scan the virus, we see exactly what it is, and we right there develop a diagnostics and then make that available. But we also make sure that we capture the data. We're creating tools for data capture and data analytics. And then make sure that the data are actually released so that somebody that is in government actually will just see, we'll just have a display and then eventually visualization is very helpful. They just know. What they want to know is what is happening, or how things are going. So we create such platform in terms of sharing information and data. But more importantly is the fact that we have, through this program, empowered the frontline healthcare workers who have been in this field in using the next generation diagnostic that we're creating and also the data capture system, so that at the end of the day, informations are released in real time from the grassroots up to the ministries and their different levels, and all the way to the Africa Center for Disease Control.
Excellent. So, again, that importance of data and the translation and a lot of success in Nigeria. But we missed a diphtheria outbreak, 200 days to detection. The Lassa fever outbreak continues to rage in Nigeria. So still a long way to go, and the importance of getting into those communities, building trust, and some of the amazing work Last Mile Health and other community partners have done. So maybe I can hand over to you, Raj, and hear about your work.
Sure. My relationship with pandemics really started when I was a kid, because my mother would keep prescribing chloroquine out of her shelf at home to us every time we got bouts of malaria in Liberia, where I grew up. She probably single-handedly contributed to chloroquine and antimicrobial resistance in West Africa. So I feel like, as all good sons do, you kind of have to make up for all the good deeds of your parents. So I went on to become a physician in the United States after my family fled there from the Civil War. So that's really my first orientation to, or second, I should say, is caring for patients. And like Dr. Happi, felt very much that what do they say? Service starts at home. My mother used to say charity starts at home, or work starts at home. And so Liberia, of course, went through after the Civil War such a devastation economically, but health-wise, they had just about 50 doctors left for a country of 4 million people. And that meant that conditions like HIV and AIDS in the year 2006, although antiretroviral treatments, countermeasures as we like to call them now, were available for years and years, but hadn't reached people in rural areas where those doctors were nowhere nearby, days away from those rural communities. So when I went back home to Liberia, those are the communities I was most interested in working with. And one of the first things Last Mile Health did, working with the government of Liberia at the time, was to help roll out and decentralize antiretroviral treatment. And of course, when you do that, and you realize you have a shortage of doctors and nurses, you have to hire and train and equip community health workers, those people from the communities themselves who can be part of the medical team, really extend the reach of the healthcare system. I don't think any of us knew at that time, several years later, during the West Africa Ebola outbreak, history's worst Ebola outbreak, and many in this room were involved in responding to that effort. It was the first time Last Mile Health really worked with the Skoll Foundation, which was, to the credit of the Skoll Foundation. I guess I don't know. I guess it's awkward to say that now, but it's worth noting that I think you'll hear the theme of delay as being associated with suffering and death and bad outcomes in pandemics. And curing that delay, as my friend Ari Johnson likes to say, is part of the work. It's speed. Philanthropy in the West Africa Ebola outbreak was much more rapid than governments were in responding, in locking funding to those responses. And so what was going to, at one point, estimated to potentially kill up to 1 million plus people in West Africa was averted because of the response of philanthropy and social entrepreneurs and, of course, local governments in the end. But look, 30,000 people died almost, 11,000 people died, almost 30,000 were infected. And that is not a good outcome when you're dealing with Ebola. It is something that shouldn't happen. And the community health worker approach was critical, again, in bringing care to people and ensuring that the testing and the contact tracing and the treatment was received more quickly by people at risk. That communities who were afraid to go seek any of those things, testing or treatment, were actually educated by their neighbors about the signs and symptoms of Ebola. And so that approach to community-based responses, again, as a physician during the COVID pandemic, I again remember seeing how powerful that was. The state of Massachusetts had, in an epicenter called Chelsea, a poor neighborhood that had had about 5 or 6 times the statewide average of cases. Vaccines had just been rolled out in the state in January of 2020. By April 2021. By April 2021, the statewide average was about 30 or 40 percentage points higher than Chelsea's local community vaccination coverage for COVID. How did they close the gap? Grants were given to local community education centers that then recruited in physicians and nurses, some of us to volunteer. And on the first day in that community, largely an immigrant community, 350 people showed up to get vaccinated. And I asked, how did you all manage to do that? It's a Sunday, and the coverage rates were 40 percentage points off. And they said they had sent, because they're a local cultural education center, they knew the community. They had taken folks who were educators on job education and retrained them to go door to door to get people registered for their appointments for vaccination, to give them masks, to give them hand sanitizers. A lot of them had lost their jobs because they were taxi drivers or they were working in jobs that ultimately got laid off at the beginning of the pandemic. And they said, come over to the education center and we'll still also help you find a job again. And that's what got all those people in. And within 4 weeks, that community caught up with the Massachusetts statewide average. So to me, that theme of bring care to people, don't wait for them to come to care. The idea that medical breakthroughs are necessary, but they're not enough. We've actually got to get them to people. Has been a consistent, I think, pattern I've observed, whether it's as a physician working with Last Mile Health, the Skoll Foundation. And my current day job is working at the White House, supporting the President Biden on the pandemic team. All protocols observed, as we like to say. I'm here in my personal capacity today, so I won't officially comment on administration policy, but seeing it from a policy perspective, I'm even more convinced that it's the kind of work that you're hearing about here on this panel, and the work you're doing at Resolve to save lives, that we need to do more of. If we've got to be more proximal in the way we deal with pandemics. And then, as you noted at the top, the way we prevent pandemics is by responding to the outbreaks of Marburg in Tanzania and Equatorial Guinea, by responding to the numerous cholera outbreaks, by responding to the risk of anti-malarial resistance, which again, forgive my mother, please, for helping contribute to that. But malaria, TB, and HIV, it turns out, last time I checked, also are major epidemics and pandemics. So, it's kind of like I tell my kids when they use dumbbells that I don't ever use because my jobs don't ever allow me to exercise at home. It's like, to build muscle, use it. You build your preparedness muscle by using your response muscle.
Couldn't agree more. So we've heard a lot about the new innovations, the connection between finding disease outbreaks, speed, communities. These are lessons that we've documented. I remember, as Raj would have, many of us went on the junket that was post-Ebola lessons learned. I think that gave me more PTSD than the actual response. But these are not new lessons. Even with COVID, all of the large reviews that we've had, these are lessons that we've documented over many, many years. And so I think I'd be remiss that the main question is, are we ready for the next pandemic? So I'm going to ask you, are we ready for the next pandemic? And if we're not, what else do we need to do to be able to get there?
Yeah.
Maybe we'll just go down the panel again.
It depends on like the level of readiness. Generally, I would say maybe. Yeah, not yes, but not no, but like maybe. It depends on, I think, like many level of readiness, as I mentioned earlier. For example, like if we talk about the medical breakthrough, for example, the new platform of the vaccine, we're probably ready that the mRNA platform would speed up the rollout of the new kind of vaccine. But that's a hard science. But if we look into the other area, we probably like need to look into like different stakeholders in the community. Like, for example, I need to look into the note, like the citizen part. Mm-hmm. For example, like family. Are our families members ready for the next pandemic? I hope none of your relative has been lost during the pandemic. I know someone who lost their family members, and it's still like traumatized them. So I don't think those families were ready. For our kids, like my kids, 4 years old, at the time he couldn't go to school because of the lockdown. So we need to put them out of the school and do like kind of like homeschooling and if you have kids during the pandemic and also like the university students, college students, it's pretty strange time to study remotely through the Zoom, to Google Meet or whatever. And like I'm afraid that this generation of students lost some connection with the society, lost some of the soft skills that they could build up in the school. So I don't think they are kind of like ready to the next pandemic. And for the society and like businesses, like lots of business gone out of the business. And like the pandemic accelerate and widen the inequity of the society, of the access of the health, the access of the education, or of those inequity. I don't think the society is ready for that, yep. for the next pandemic. So what we could do, I think there would be like multiple things that we are working on. Scientific breakthrough, the new way, you were mentioned about the safety net for the society. Those kind of things need to be done and need to be established for our society to be ready for that. From my narrow perspective on the surveillance, like how can we detect and hopefully stop the next pandemic, is like I think we need to expand the way we look into the health threat in the future. Currently, I would say like the majority of the disease surveillance, we rely on the traditional data. So people need to get sick and go to the hospital. I would hope for the more participatory approach for this. So people can be eyes and ears and arms and legs to detect and respond to the any sign in the community level, and hopefully we at the early days of the pandemic we were talking about like flattening the curve, right? We never done that. Like we failed gracefully, right? So like, woo, it's go skyrocketing. But if we enable community to be able to detect and respond, we could hopefully like flattening the curve and make this. Dr. Happi will mention about like sharing the data, like make this data available for everyone who need to respond and detect this and like let them work together. So I think like from at least from my field of work, participatory approach can like reduce the risk of the next pandemic and make us ready.
Yeah. So I think it's that acknowledging, to some extent, doctors and nurses, healthcare workers, we need to let go, right? This is going to take everyone. It can't just be our work, it has to be everyone's work. Angela, are we ready?
Are we going to have another pandemic? Yes. I think probably within my lifetime, not even the next generation. Do we have what it takes to prevent the next pandemic? It depends on how we use the tools that we have. I don't think we need more tools. I think we have all the tools we need. Maybe there are some more tools, I'm sure. I don't know about everything. But I think fundamental for me is the approach and the governance. COVID response was a very top-down approach. It didn't have people at the center. It didn't have the most vulnerable people at the center. They were nowhere in the picture. In India, we had the great migration because we suddenly shut down the entire country. There were people trying to go back to their homes. It was agricultural season. We did not have reporting of how many people died because they didn't have food. It wasn't about COVID. There are countries even now getting money for COVID vaccinations that don't need it. They have other deaths happening. So when are we going to put the people at the center and really adopt a whole of the society approach? Ken and I were talking last week because I found his work very interesting, and I was talking to him and saying, how can people who work with the communities work with the health department? And he said, well, I work with the agricultural department and they respect me more. And so for that outcome to happen, we also need to be creative on who all the stakeholders are. If you're going to talk about antimicrobial resistance, we can't just work with the Ministry of Health. We have to work with the Ministry of Animal Husbandry. But most important is the outcome for the people. So I really think that we can prevent the pandemic if we have a whole of the society approach, have intersectoral governance, which includes people, but also across the ministries from bottom to top, because the action actually happens at the bottom. And then, yes, I think we can prevent the next pandemic. So I'll end with a little bit of
hope.
With hope.
With hope.
With hope.
Excellent. Dr. Happi, are we ready?
I will say no. We're not ready, and simply because as we failed to learn. We've been going on from epidemic to epidemic for ages, and we still have to struggle and grapple. And right now, I think the situation, I get worried if we have an epidemic coming or a pandemic coming in the future, because it seems to me that, yes, we develop new tools, but behaviorally, we've gone back 50 years behind. It's going to be very challenging. Think about people in developing countries who contributed data, right? Open access, open sharing, and then you have farmers that take it and then run with it, and then suddenly, you contribute data. At the end of the day, there's no benefit for data sharing. So, it is encouraging for people to release the data. Think about countries that actually went on all willingly to identify new variants and make it available to the globe so that we can use it to develop countermeasures. And then they get stigmatized, they get victimized. Is it this that we want to go forward? I think we have to change our behaviors, and we have to be more I think, human in the way we are doing things. So for us to prevent the next pandemic, it's not just about saying that we're having the tools, but our behaviors are going to determine exactly how we can prevent this. And this is not just for us. I think it has to involve government. We're seeing our colleagues here. Everybody, we create a system called Sentinel because we believe that every citizen should be a sentinel. But then that requires for us to do massive education. And also, most importantly, trust. I mean, if there's no trust, does the citizen trust his government? Do we trust one another? So these are things that we need to really think about, to prevent the next pandemic. Otherwise, we just keep talking the talk and then not walking the walk. But I want to believe that through platforms like this and then through, Skoll and then all of us here, we need to start singing that song of hope and then go back and then start doing the right thing. And then start letting people know that, look, I mean, we shouldn't just look at these pathogens as pathogens. I've said it before. We as humans should really be seeing ourselves as a species, as endangered species, because if you are not careful, we're going to be taken over by these microorganisms and these pathogens. So once we start reasoning that way, that we are the ones endangered, not this pathogen, then we'll start working collectively to do the right thing so that we can actually address things holistically. Because as long as we think that we're in our comfort zone, wherever we are, and then we think that, oh no, this will never get to us. Whatever starts in the most remote place in the world can get to the most, to the biggest, biggest, capital or capitals in the world within 36 hours. They are just flight away. So if you understand this, it means that one incident anywhere should be considered as something that is global, and we should respond to it and respond most effectively. Thank you.
Yeah, I think to get more ready, we've got to first acknowledge and speak about the risk that is growing. In medical school, I wasn't the smartest kid, so I had to alliterate everything. So forgive me for a second doing that, try to remember facts. But there's 3 Ps, right? There's pathogen spillover. Is that growing or shrinking in risk? It's growing because the risk, to your point about remote communities in the countries you and I have grown up and worked in, those primary rainforests are being deforested. And at the Skoll Foundation, we get to work on climate with a lot of entrepreneurs working on the climate side of the work and also on the pandemic prevention side. And you can see and hear about deforestation as a big gap. Why does that matter? Because when you lose a forest, more contact comes between animals who harbor some of the microbes we haven't been exposed to and the humans who then might get them and where a new pandemic can set off. The other P, you just spoke about it as well, is population movement. I mean, we've seen much more displacement. We've seen much more migration from rural areas to urban areas because of poverty and because of inequality. That doesn't seem like it's going away. It's going to grow. The time, as you said, between, say, a Lagos and a Monrovia, as we learned during the West Africa Ebola, is only a couple of hours. Humans are going to get probably more efficient at moving people and goods from one place to another. And the third P, of course, is what's always been there in the first place, which is poor public health systems and healthcare systems in those settings. And in the most rural parts of our world, where those first 2 risks are growing, we haven't done enough when you have billions of people out of reach of the basic things they need, when you don't have epidemiologists, disease detectives, community health workers, nurses, doctors, and hospitals in the right places, when you don't have testing. So those are going to grow. So I think we've got to talk more about that. Otherwise, this can sound like a theoretical conversation about some future risk. It's actually an everyday risk. And the second thing I think we've got to do is to really be much more systematic about efficiency, about effectiveness, and about equity. And if we take the 5 core actions of responding to epidemics and outbreaks every day, we got to be better at preventing, we've got to be better at detecting, we've got to be better at preparing, we've got to be better at responding, and we've got to be better at recovering from these efforts. If you use that as a framework, then the next question, there's a number of things we could do in all of those areas. We've got to do a lot, and I think your point's really well taken. Some of it is about stuff. We've got new ways to detect pathogens through the use of wastewater surveillance. We have the kind of work you're doing to scale up genomic surveillance and next generation sequencing in many more places. We got to put more support behind that. But we've got to put more support behind trying to get vaccines in not 300 plus days, but in 100 days. But we've also got to put funding behind and support behind how we get those vaccines in people's arms, not in what's almost took about 1,000 days to get to 70% coverage around the world, even just with one dose of COVID-19 vaccine, and shorten that. Could we shorten it to less than 6 months? Could we make a commitment that every time a new epidemic or pandemic happens, that in 6 months or less, we will ensure not only that a vaccine is produced in 100 days or less if we need one, but that if that one exists and if one's needed to be built, that we get that vaccine into every person's arm that needs it in the world within 180 days. It's actually scientifically possible to do that with the right resources. And so I think we've got to do that. But when it comes to response, and I want to commend the work you've been doing, Amanda, on this, we've got to be a lot more clear about taking. We can easily pat ourselves on the back for, say, stopping the Ebola outbreak from becoming West Africa Ebola outbreak from becoming even worse. The work that was done this fall on stopping the outbreak of Ebola in Uganda, which was threatening to become an even worse outbreak, and getting to 0 cases in less than 100 days, is something that should be celebrated, and vaccines didn't get there until the days after the last cases. So I think we've got to be a lot more honest about what good looks like. And I think the rubric of detect in 7 days, that anytime there's an outbreak in the world, a local health system should be able to detect that and ensure that within 1 day that it's reported to a national local health system. And then within the next 7 days, an effective, efficient, equitable response is mobilized. That 717 approach is the kind of thing we could all rally behind. We could, if you're in health, you can push for that. You can practice that. If you're outside of health, because we all know pandemics are not just a health issue, you can hold your governments accountable to reach that. If you're in philanthropy, you can ensure that when people say they're working on preventing pandemics, that they're actually reporting on metrics like that. And so I think that kind of will force an honesty about whether or not we're getting more and more ready or not. So to me, that is a critical thing. We've applied that kind of thinking in Southeast Asia to, and I see Rob Newman here, who was leading the malaria program at WHO for a while, the idea that to malaria. And because of that capability, because that capability was also built after the first SARS-1 in Southeast Asia, the Southeast Asian nations, compared to where they were economically in their health systems, actually punched way above their weight. That wasn't a coincidence. And I know that because even in my other role, when we track avian influenza, I think a few weeks ago, I see the room here, it's basically pandemic nerds, if I don't mind you calling it. So you all were tracking this, but we were all holding our breath when a little girl fell sick in Cambodia a few weeks ago. She's 11 years old. She's in a rural forest. She died because she contracted bird flu.
Yeah.
Now, the first thing everybody was thinking about in this room is about the girl and her family, because her dad also fell sick. And the second thing we're thinking about is, are more people in her community going to get sick? And is this going to spread person to person? Is this the moment for the next pandemic? Right? Holding your breath. Losing hair. And what happened? The Cambodians, who have been drilling on 717, who have been working on malaria every single day, who have been who responded to SARS-CoV-2, got the COVID vaccination rate up because they leveraged village health workers. They used that same system. They got their disease detectives over to that girl's village. They went right next door and saw there about a dozen other people who were contacts of the dad and the girl. They asked them about their symptoms. They got samples from them. They sent it to the reference lab. They got the village health workers to work with the local veterinarians to sample the birds and the ducks in the community that they had had, and they found that those birds had avian flu, and the only 2 people in the community that had it were Dad and this little girl. The other 12 people didn't, and we then knew that this is likely not to spread. But that capability doesn't exist everywhere in the world. We've got to get there.
Thank you so much. And I think, the takeaway there for me is, to some extent, it has to be doing the basics well, fast and consistently. And that's the work that we've been promoting around the 717. And thank you, Raj, for bringing that up. We do think that we could rally around that the way that 90-90-90 helped people rally and make progress in HIV and have a common goal and a common metric. We think 717 could do something similar for the public health nerds in the room and beyond. And there's so many people in the room. I want to get to the questions. But one thing that hasn't come up that really struck me from the opening that maybe I can just ask one of you to reflect on, the opening around information and the loss of truth, the fact that we don't have a shared reality, the importance that you all talked about in terms of being able to reach that last mile and how important trust is. It shook me in the opening that's at risk. And it wasn't one of your 3 Ps, Raj. So where does the lack of truth and trust...
It starts with a T, that's why.
Yeah. But I wonder if we don't need to add it to the list. This for me is a growing risk, this lack of trust, this disparity in understanding what the truth is. So, it's a huge topic, but it did really resonate with me from that opening ceremony all the way through. Does anyone want to tackle that question in terms of where does that sit on the risk barometer to all of the work that we're doing to build better systems, to make sure that we can have the tools that we need, could be completely undermined by politics and that lack of trust, that new information. Anyone want to take a shot at that? Angela.
I first want to thank Skoll Foundation for trusting us with this piece. Surveillance is very tricky, and as you said, COVID information was extremely politicized. And we took the risk of having a public dashboard. And I think that required a lot of navigation with the government. And if you look at all the surveillance, I think in your country you have surveillance systems with a public dashboard, but it's not so much over there. And so it's really hard to solve for information asymmetry. It's really hard. I think the trust within the public health institutions or health institutions the lack of trust was magnified. The lack of trust with the government was magnified, which made their work even harder because they had good intent, but they also had to protect whatever they had to protect. I think if we were to adopt a whole of society approach that requires radical candor, crazy amount of collaboration and trust building. And I mean, trust building is sort of it's a hard road, but I do think that it would be really hard to be truly prepared for the next pandemic if you didn't have that.
Yeah.
Just to add on that point, I think the trust is built at home, right? It's built in communities. It's the neighbors you trust. It's the ones you go to church with, or the ones you go to the temple with. It's the ones you send your kids to school with. And so whatever we can do to educate, enlist, employ even, again, I'm very proud of the work that groups like Last Mile Health, the Skoll Foundation, the whole network of nonprofits that they work with, the Community Health Impact Coalition, there's just work that they're doing every single day to hire, train, equip local community health workers. But that's just the quarterback for that. That's community health workers working with a local midwife, a traditional healer, a laborer that's in that community. And that approach will matter. And I'll just give you one anecdote about how it mattered in COVID. Liberia at one point was the 3rd poorest country on earth. It became the 3rd country in Africa to reach 70% COVID vaccine coverage. It has of COVID vaccine coverage that's above 85% now, around the mid-80s, higher than many countries, including richer ones. I'm not going to name names.
United States.
And And you ask how that happened. After the Ebola epidemic, a key ingredient in this recipe, after the Ebola epidemic, President Sirleaf and now President Weah said, we're going to invest in a national network of first responders at the community level. Our post-COVID or post-Ebola chapter, right? This epidemic didn't end when the last case happened. They wanted to write a new chapter, and they said, we're going to have them trained on trying to find unexplained death in the community, viral hemorrhagic fevers, but they're going to do that as part of an everyday effort to treat malaria, to make sure people with HIV get care, those who need maternal care get it. They're linked to the rest of the hospital system and the healthcare system. That same network of about now almost 5,000 community health workers were vaccinated, first of all. First, they were given PPE, because they're usually left out of it, to do the education, the contact tracing, and everything else. Then when vaccines came out, they were vaccinated with other frontline workers, as they should be. Because they've been paid, they've been part of the system for so long, so the nurses that worked with them were able to train them on starting to address vaccine hesitancy in the community, which was in Liberia too. And the community health workers, as they went door to door, talking to people to try to convince them to get the vaccines, of course people were worried, as they are in many parts of the world when there's a new thing. The way they got around that, in part, was to take their own vaccine cards and wear it and show them that they had it. Talk about wearing your heart on your sleeves, right? That type of work is needed because ultimately trust is the secret sauce of community health workers or community-based approaches.
Absolutely.
And as you've pointed out, trust is the key ingredient in the pandemic response recipe, right? And so we've got to do that, though, every single day.
Thanks so much. Right, well, we'll go to the... and I know we don't have long, but maybe I can ask Ian and then Caitlin, and we'll move to this side of the room.
So I've been working in this space for 40 years. Hard to believe. I'm very encouraged that we have this session. I'm somewhat disappointed that the room isn't full. I'm hoping that there are more people online. And I saw evidence yesterday as we were gathering that people think the pandemic's over, when many of us know that it's not. I just wanted to run through a few points that sort of represent 4 decades of work that I think is very important to capture. Some of it's been captured, but it hasn't been emphasized adequately. The identification of the threat can now be done very rapidly, but only really in developing countries. I think Christian's efforts are an example of what we need, but it needs to be even broader in terms of scope. We need people who understand the epidemiology, can go out and figure out how infectious agents are transmitted, and we need to more rapidly identify potential treatments that can mitigate disease. The vaccine platforms are great. We congratulate ourselves on how wonderful they were, but I was not thrilled with the idea, first of all, that they didn't do much about preventing transmission. They were primarily focused on reducing the burden of disease. Very important, but we need vaccines that work at mucosal surfaces. And I don't see a lot of investment there. And Raj, I think you should push for that. We need to find ways in which we can rapidly validate diagnostics, drugs, and vaccines. As a pandemic moves or outbreaks move, the patients you need to test will also shift. So if we had the equivalent of an international FDA that could regulate and approve these things, we would be much further along. Data sharing has been a huge problem. Sample sharing as well. We saw this in China, we've seen it in other places. This needs to improve. We haven't talked at all about research-related risks. I think they may be overstated, but there's a very strong lobby that thinks that this is a huge problem. And with the proliferation of these BSL-3 and BSL-4 laboratories worldwide, we need international regulations that provide guidance so that we don't have problems. There's already enormous pushback in the US and in Europe about these laboratories, and there are people who might contribute who are being discouraged from going into this kind of work. Climate change is hugely important. The distribution of phlebotomous insects is spreading. Furthermore, their growing periods are longer than they were before. 5 years ago, we went into Gorakhpur, where there was flooding at the headwaters of the Ganges, and we found that there were novel rickettsia. They were killing young children. Food security, I forget who mentioned that, but that is another very, very important thing. Most parts of the world, people have monocultures. So we have found viruses that kill fish and kill fowl and so forth. This is extremely important. And population migration should not be underestimated.
Yeah.
Anytime we have mass gatherings, we have an opportunity for these agents to adapt and spread. So will we have another pandemic? Maybe yes, maybe no, but we will definitely have outbreaks. And if we practice on those outbreaks, we'll be able to minimize risk. Thank you.
Thanks so much, Ian. Maybe I'll take 2 or 3 questions and then turn to the panel. So Caitlin, and then I'll come over to you.
Yeah, thanks for this great panel. One theme I heard throughout was the value of trusted messengers, community health workers, communicators on the ground. And trusted messengers were huge in COVID, especially in the United States, when there was very lack of trust. And so I guess my question to the panel is, when we go through these valleys and peaks of epidemics and pandemics, how do we keep that network that we've built of trusted messengers, of community health workers in reach so it can be activated or deactivated when we need it or not? And how do we sustain and maintain that?
Great. And then it's up in the back in the middle, and then one from the front here, Robert, and then we'll ask the panel to respond.
Thank you very much. My name is Frida. I'm from ID Insight. I'm a medical practitioner as well. I have a couple questions. I think that was a very interesting panel, honestly, to discuss this, and very, very good points. I just wanted to ask, a couple of questions around some of the bottlenecks that we've faced. So some of them are, in resources. Like in the case of Ebola, we knew. I think some of the panelists already mentioned how long it took to get the resources. Where they were needed, including financial resources. I wanted to hear more about how prepared we are financially to ensure those resources are available, but also to be able to mobilize them adequately. Do we have, I know a few bilateral organizations, maybe even a few multilateral organizations have pandemic emergency financing strategies. How many other organizations do? How many countries have this? And we have protocols to release those resources, so that even when the monies are there, we're not having other bottlenecks in terms of the protocols. And related to that, I think in several countries, including Kenya, where I live, so there was the health pandemic and also there was the economic pandemic. Do we have resources to support, businesses and communities so that, even if we lock down again, we're not ending up with more deaths because of, malnutrition and so on? So that's one. The other question I wanted to ask was about support for, do many of the countries, and I'm asking this because I really don't know, but I want to hear what are we doing to ensure that countries have the protocols and tools required to, allow them to quickly approve, pharmaceutical commodities, etc. Just really all the bottlenecks that actually ensure that even though the money is there, vaccines are there, that we're actually taking very long, like Raj said, to actually get them into people's arms and so on. Do countries have guides or handbooks on how to deal with each of these? As was mentioned earlier, I think Dr. Happi mentioned this, that really, especially for a respiratory virus, it's just a few hours before it gets to other countries. Do all the countries have the required systems to, guides, etc., to handle pandemics, and what are we doing in that regard? And I think all this really goes back to resources. Thanks.
Thanks, Frida. And Robert, we'll take one more question before we go to the panel.
Thanks very much. Great discussion. Robert Newman, Executive Director of AMP Health. Just want to sort of comment/question, but building on some of the things I heard from the panel. I heard, a couple things that really emerged for me listening was the importance of governance, intersectoral collaboration, trust. Really, community trust is critical. I mean, I think we talked a lot about that. But I think one of the things we don't talk a lot about is the collective leadership and sort of the trust required at senior level amongst different parts of government to actually have an effective response. You know, if you look at what happened in COVID, the determinant of how the pandemic evolved at country level really revolved around leadership and management. You needed empathic and evidence-informed leaders who are willing to understand and feel the suffering of their communities and use evidence to make decisions. And you needed meticulous management. The virus exploits places where management is not meticulous. And so, you know, we talk a lot about the tools, but I'm not sure we're talking enough about the leadership and management that's required, which is really gets back to the governance issue. And I'm glad to hear Raj bring up Cambodia, where I used to live. I was the US CDC country director in Cambodia and point person for GHSA at the time. And Lee Savan, who leads the Cambodian CDC, I think is a great example of someone who's learned how to convene across government, bring everyone into the room, have a conversation. And that sort of collective leadership is really important. And the idea that we're exploring with some very generous seed money from Skoll is this idea of, can we bring together teams across ministries of health and potentially beyond and put them through a leadership and management journey as a team, right? What are they trying to achieve? How are they trying to prepare? And what are the leadership skills that they need as a group to get there? How do they acquire those skills experientially as a group so that when the time comes, they're not trying to work together for the first time. They have a track record. They know how to work together. They understand strategic planning, vision setting, brokering partnerships, influencing without authority, managing in a crisis, all those things that if it's a crisis, it's too late to be learning those things together. So this is, you know, I'd love to hear your thoughts as a panel if anybody's interested in this, but this is something that, you know, look, I come from a public health background. As Raj said, I used to be director of malaria at WHO. But it was during those years that I had this epiphany that it wasn't lack of technical knowledge as much as it was lack of the leadership and management skills to, you know, conduct complex programs, you know, not during a pandemic, but that the stakes are even higher when you're in the midst of an emergency. Thanks very much.
Thanks so much, Robert. So I'm going to turn to our panel. I'm almost failing on my moderating duty, so maybe I can ask each of the panelists to take 2 to 3 minutes to respond to one of the questions or sum up your experience.
So for the maintaining the level of participation, I think like we need to go back, like what kind of benefit that we give it to the community or to the volunteers that help us monitor. For example, like in Thailand, there was like two kinds of volunteers. One is like government employee volunteers. We shouldn't call that volunteer because like it's employee. But they would get like monetary compensation. But that's not for our case. For our case, we started with monetary. We get the farmer with monetary compensation, but after like 2 years, they asked us to stop doing that because they felt that it won't be sustainable. So we try to find the other way. For example, like give them the reputation, promote them to be the village leaders. So the volunteer keep engaging with the monitoring and response activities. And for the Robert question, I totally agree about like kind of like lack of leadership skill. I use this kind of analogy into the team when we talk about how can we like stop the next pandemic. We probably need to think that how can we stop the alien invasion, because they doesn't care about the politics. They doesn't care about the race. So the way to stop the next pandemic probably would be the similar way to how can we stop the alien invasion. So we need international collaboration, and it goes beyond the geopolitics, and like very high collaboration across sector and this is not like the any specific country issues. It's humanity issues. So we need to think that way. I don't have the solution right now, but probably alien invasion would be the way.
Okay,
Yeah.
Angela.
Just a quick one to Robert. I've seen more integration in terms of governance as we get more proximal to the communities and less so upward, and maybe having more faith and in those institutions, more financing, more autonomy might be one way forward, because those are the people who live there and are seeing stuff right in front of them. So just very simplistic response, but that's just sort of my lived experience. And to Caitlin, my favorite question is on the trust in the community workers. I think if we have an extractive approach, just go in there because there's HIV or there's COVID today and water sanitation tomorrow, those ones never, so literally never survive. But if we or someone working there, community-based organization, strengthen those institutions with the people in the center, so it could be electricity tomorrow, it could be gender violence day after, it could be food, it could be clean water. That community institution is strong, then you have strong leaders and are able to work through them, so it doesn't matter if it's Ebola or COVID or HIV or something else. Those are the champions that can even navigate religious riots. And so nurturing those institutions with uncompromising compassion and a deep commitment for their overall development, I think, for me, resonates with me. And those are some of the communities that not just sort of survive but also thrive.
Yeah. Again, thank you very much. I think I will go with a sister from Uganda, just to say that. You talked a lot about, investment and then the resources and then the need. But I want to say also that, I think we've got to be very intentional about investment. And this definitely goes to my fellow Africans. I think we tend to miss our priorities and not to invest where our mouth is. And as a people, we need to definitely make a lot of investment in that space. And investment means it's not always about money, but actually just empowering people. And we got opportunity here, where we probably will not, let's say we're exiting this pandemic, but to learn from what has passed, from the past, and then start really empowering those local communities. And then leadership, again, to come to Rob, it's really not always at the top, but can we start really having grassroots leadership building in a way that people understand that the destiny of their community actually starts with them. And then that bottom-top approach will be very important. Now, we also have that responsibility to help, because it's important that our politicians understand that human life is more than the rhetoric and things that they actually say. And here, I wonder at times if we do have this United Nations summit where we have all these heads of state coming all the time. If it is not necessary to have a session for all those leaders while they are there, a real, if it's just 2 hours, training, let them see that they own that whole responsibility. And I don't know, I think you got what it takes maybe to have insight in such places. I think it's important to really do that so that we have a bottom-up approach, but then also those that are really leading should understand that they are the guides of those countries and the communities where they come from. I think that would be very helpful to address. And I think finally, for me, I do believe that, whatever we do, if we don't take responsibility as individuals, because everything starts and ends with us. So what do we do as individuals? Do we just sit back and then allow things to happen, or do we try as much as we can as individuals to try, to make some of these things that we're saying here reality in a way that it could have that little impact that starts somewhere and then starts spreading. So I think that's, for me, I think it's going to be very important going forward, that we show leadership at every level, but starting with self.
Very well said.
I'll just comment on one or two. I think Robert's point about leadership and management really resonates. I would just argue that that has to include drills on pandemic preparedness and response. Yeah. It should include not just health folks and cross-sectoral, it also needs to include the equivalent of whatever the presidency is in those countries. Because ultimately pandemics, when you have that kind of sectoral coordination needed, it's only the folks above that can help instill that. And I think the other thing it needs to have, to the points that are made very eloquently here, is that those community leaders need to be part of those drills before there's the next pandemic. On financing, there's a big push right now to try to get so-called zero-day financing. When you look at some of the analyses that have been done around why it took so long to get vaccine from December 2020 in one person's arm to where we are today, there's many different factors. But if we want to close the days, one of the key factors is ensuring that those who are working to not only research, develop and approve a vaccine, or we haven't talked enough about treatments here. Antivirals can be produced in 90 days if they're repurposed, novel therapies in 180 days. Testing also needs to be more rapidly scaled up. But all of that research and approval process needs to go faster while still remaining safe. But then the next delay is making enough of it and then making sure it is bought. That could be done through like the Africa Medical Supplies platform that the Africa CD stood up, or it could be sometimes global when it is global and some of those big institutes could be bought by a country. But what's missing there and caused a lot of delays, because say Gavi and others had to be further back in the line, they couldn't put their orders in with companies, is because the financing wasn't there on day zero. Everyone can say that if we spend billions on preparedness, we could save trillions of dollars and millions of lives, but only if a decent amount of that money is available on day zero of a pandemic. So there's work being done to figure out what forms of capital and liquidity would be in place to make that possible for those who need to buy enough product at the beginning, test treatments, vaccines, on day zero, as close to it as possible. So we're not spending time having to raise capital to the extent possible in those early days of the responses, and that ends up leading to the loss of life. I guess I'll just say that the last thing is, I fundamentally believe that there really is a moment right now. By the way, Ian, I couldn't agree with you more about the risk of lab accidents. There's also, we haven't talked about here, is the risk of deliberate threats. And while it's meaning the use of biological weapons by state or non-state actors, and that too needs to be a focus. But the United States put out recently in the public domain a national biodefense strategy. That's essentially the nation's plan to make the country and the world safer from pandemic and other biological threats. And in it is a focus on naturally occurring laboratory and deliberate threats. And in it is a focus on many of the things we have here. Countries have these national action plans for health security. All of us have got to look at those and ask if they're bold enough, efficient enough, equitable enough, and going to be effective. And that reform needs to happen now. I think if we can do it now, not later, then I think we have a better chance at least minimizing the impacts of pandemics, preventing them when we can, and just at least learning from one to the next one and doing better each time.
Thanks so much, Raj. And I think ending on a little bit of hope there in terms of the way forward. Maybe just a final remark from my side. I think one of the words or phrases that I learned here this week was system orchestrator. And I think as we hear about all of the challenges, the complexity, the wicked problem that is pandemic preparedness, the need for orchestration between all of us, between the grassroots community and the individual, all the way up to the president. It's everyone's job. It goes from innovation all the way through to doing the basics, getting soap and water where we need it, getting genomics when we need it. So there's a real need to think about the challenges in a comprehensive and systems approach. How do all these pieces fit together? How do we leverage the new innovations and the grassroots disease detectives, using farmers to find those outbreaks, all the way up to connecting and using that data to inform presidents and make well-informed decisions, releasing money quickly, and really thinking about how we do that consistently and with speed. And I think it's the challenge of our generation. We have a moment now to make that change, but we have to change the system. The system has performed the same way for the last 100 years. And so as we move forward, how are we breaking down that system and rebuilding it, restructuring it in a way that works for everyone and fills those equity gaps so that the viruses can't find those gaps in our systems and exploit it the way that COVID did. So I hope we all leave here with a little bit of hope, but with a sense of urgency and a challenge to build forward better. And hopefully we prevent the next pandemic by meeting the challenge of everyday outbreaks. And so with that, thank you for your attendance and support this week. Thank you so much to Skoll.